Great, thank you so much. Welcome to the September 14th, 2022 Medication Error Reduction and Workforce Committee. My name is Nicole Tebow, Chairperson of the committee. Before we convene, I would like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. As I have previously shared, I believe medication errors are the #1 patient safety issues facing pharmacy. During our prior meetings, we have received several presentations providing education to the committee. During this meeting, we will begin to consider some policy-related issues. This meeting is being conducted consistent with the provisions of Government Code Section 11133. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must join the WebEx meeting. Information and instructions are posted on our website. As I facilitate this meeting, I will announce when we are accepting public comments. I have advised the meeting moderator to allot 3 minutes to each individual providing comments. I would like to ask staff moderating the meeting to provide general instructions to members of the public participating via WebEx.
This is the moderator. To facilitate public comment today, we will be utilizing the WebEx question and answer feature. When the committee chair reaches a point in the agenda at which public comment is appropriate, public comment will be requested. And at their direction, I will turn on and announce the opening of the Q&A feature. Members of the public can indicate that they would like to make a comment by clicking the icon with a question mark within a square located at the bottom right-hand corner of their WebEx screen, and the instructions will be shared on screen each time for your reference. In the Ask field, typically in the lower right-hand corner of your WebEx screen, members of the public who wish to make public comment can type, "I would like to make a comment," or simply comment, and send to all panelists. Any other communication will not be responded to. Members of the public, it is not necessary to identify yourself in order to make public comment, and I will take public comment in the order that they are received. We will call on the member of the public and ask that they unmute their microphone, and they will be given 3 minutes to speak and a 10-second warning. At the conclusion, their microphone will be muted, and we will move on to the next member of the public who has comment. And I believe that is all the instructions that I have.
Great, thank you so much. I'd now like to take a roll call to establish a quorum. Members, as I call your name, please remember to open your line before speaking. Sung Oh.
Hi, Nicole. Hi, everyone. I'm here.
Morning. Jesse Crowley.
Good morning. I'm here.
Hi. Kula Koenig.
Good morning, everyone. I'm here.
Good morning. And Jig Patel.
Good morning. I'm here.
Hi, Jig. A quorum has been established. We can move on to agenda item 2, public comments on items not on the agenda and agenda items for future meetings. I will now open the meeting for public comments for items not on the agenda. I would like to remind members of the public that you are not required to identify yourself, but may do so. I would also like to remind everyone that the board cannot take action on these items except to decide whether to place them on a future agenda. Members, following review of the public comments for this agenda item, I will ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the board and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Moderator, please open the lines for public comment.
This is the moderator, and at the direction of the chair, I have opened up the Q&A feature for public comment. Members of the public, if you would like to make a comment for items not on the agenda, please click the Q&A icon located at the bottom right-hand corner of your WebEx screen or use the raise hand function. Audio-only participants can use the raise hand function by pressing *3 on their device. It looks like we do have a couple requests for comments, so I'll start with our first individual, Ms. Gruwall. Ms. Gruwall, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Committee members, Jassy Graywall with UFCW Western States Council. Apologies that this is not the right moment to make this request for an agenda item. I won't be able to make it to the full board meeting, But I would like to just share, as we are in a monkeypox, while there is monkeypox and pharmacists have now been given authority to issue monkeypox intradermal vaccines, there is a training component to that I think is really worrisome. I really want to urge the board to consider hands-on training for pharmacists to do intradermal vaccinations, as well as making sure that training is away from workflow duties, so paid and not in the course of their work, to really make sure that pharmacists have the adequate training to be able to properly administer monkeypox vaccinations to the general public. So I'd love to see that as an agenda item for a future meeting to make sure that training is consistent across all employers and all healthcare settings. Thank you.
All right, this is the moderator. The raised hands that I saw earlier are no longer raised, so I believe that is it for public comment. Would you like me to close that Q&A panel?
Yes, please. Thank you. Okay, members, we cannot take action on the public comment, but please let me know if there were any items that you would like to include on a future agenda. Okay, I don't see any raised hands or any comments. So we can go ahead and move on to the next agenda item. Agenda item 3 is the discussion, consideration, and approval of draft minutes from the June 22nd, 2022 Medication Error Reduction and Workforce Committee. Members, attachment 1 includes a copy of the draft minutes from the June 22nd, 2022 meeting. Members, as we begin, I will first ask for questions or comments on the draft minutes from the June 2nd, 2022 meeting. I would also entertain a motion if you believe such action is appropriate.
Hi, Chair Tebow. I make a motion to approve the minutes. No comments.
Thank you, Sam.
This is Jake Patel. I'll second it.
Thank you, Jake. With a motion and second on the floor, I will now open the discussion for public comment on the June 22nd, 2022 draft minutes. Moderator, please open the line for public comment.
This is the moderator, and at the direction of the chair, I have opened up the Q&A feature for public comment. Members of the public, if you would like to make a comment on this item, please click the Q&A icon located at the bottom right-hand corner of your WebEx screen, or use the raise hand function. And audio-only participants can raise their hand by pressing *3 on their device. I'll pause a moment to allow the public time to access the Q&A panel and submit their requests. All right, and seeing none, would you like me to close the Q&A panel?
Yes, please. Thank you. Okay, with a motion and second and public comment received, I will now take a roll call vote. Sung?
Yes.
Jesse Crowley?
Yes.
Kula Koenig?
Yes.
Jig Patel?
Yes.
And I vote yes. Okay, the motion passes. We can move on to agenda item 4, the discussion and consideration of possible future changes to Title 16 California Code of Regulations, Section 1711, related to quality assurance programs. Members, California Code of Regulations, Section 1711, establishes the requirements for a pharmacy to establish or participate in an established quality assurance program. This program is to document and assess medication errors to determine the cause and an appropriate repose to improve the quality of pharmacy services and prevent errors. The requirements for a quality assurance program have been in place for 20 years and have remained largely unchanged and are quite broad. As we continue to evaluate medication errors and workplace issues and consider if action is appropriate to address these issues, review of the QA program requirements appears appropriate. As has been reported both in the media reports and in public comments received, Workforce strains are a contributing factor to the medication errors. However, we have received comments that some staff are prohibited from including staffing and other workforce issues as part of the QA report. Members, including in the meeting materials are some policy questions to help guide our discussion. The questions will also be displayed on the meeting slides. From a process standpoint, I intend to discuss the questions as a committee. Following our consideration of all the questions, we will then open for public comment. So the first question is going to be, should the date that the error occurred be required to be reported? What do you all think?
I'll just jump in. This is Song. I think the date should be and location, but sometimes you just can't figure out what date it happened because a lot of times you discover error and you really have to do some investigation and you can't sometimes find out when it happened. So requiring maybe a little bit hard. Maybe if it says something like if available or if can be determined. But anyway, I think Jesse was unmuting and I just jumped in. Sorry, Jesse. Go ahead. I'm gonna let you go.
It's okay. Yeah, I think it should be, like Sung said, if you're able to figure out that information, just because figuring out the date of the error can give you more information, I think, about workflow that day, staffing, who was on. I don't know. I think it gives much more information about potentially why the error occurred. So I would say if you're able to find that information, then it should be required.
Good. Chig, I see you're unmuted. Did you have a comment?
I agree with Sung and Jesse that it should be required. The date does play an important role to figure out everybody involved, who was on the schedule, working, etc. And so it should be there.
Great. I also agree, and I know that was a great point, Sung, but that sometimes you can't figure it out. So maybe it's to the best of your ability, a possible date range, that's sort of a component that we should consider. All right, great. So any other comments, members? All right, I'll move us on to question 2. Along the same lines, should the staff involved in the error be required to be documented?
So I'll just go first again.
Don't be shy.
So this gives me a little bit of pause, but as long as it's to try to improve upon what happened, and that we are maintaining just culture attitude. We're not being punitive. We're not trying to play a scapegoat. We're not trying to play blame games. Because obviously it's for them to learn, to improve upon what happened. It's not to say that, oh, it's all on you, you did this. Granted, yes, there are situations where it really was at fault by one person. A lot of times it is a systemic error that allowed this to, whatever that may be. So that's my concern. If the staff involved in the error, I'm guessing that means whoever created the error has to be documented. I think there should be some caveat to ensuring that that person is not the scapegoat for the blame of whatever happened.
Sure, good point. Jesse?
Yeah, I agree with Sung. I think it is important to know the staff involved because, again, it gives you more of a full picture image about why the error occurred. If you have the same staff working the same shift every day and that's the time in which errors occur, then you can get a bit better idea. But I agree that there is some concern about potentially having that be used as a punitive measure against an individual. And I really do want to make sure that it's viewed as a full picture thing and not just as a way to target an individual for an error.
Great. Jig, I see you're unmuted.
Thank you. Yes, I think that staff involved should be listed, as a part of the whole root cause analysis. It does, when you do the entire QA process, it does portray a whole picture of, it could be, something system related. It could be, there are so many reasons why an error occurs, and, staff involved, who did what step in the workflow. Was it data entry? Was it data verification? Where the whole, there could be a issue. But at the end of the day, I see the concerns that somebody could be, as a scapegoat, or, I see what Sung's concern is here. But knowing the players that were involved, and at the end of the day, it's not more of discipline, but learning how to prevent it in future. And if there is training or anything that's needed, and it can only be identified if we have all the staff identified during an error process and QA. So I agree that it should be part of it.
Great. Thank you, Jig. Yeah, I agree too. I think you're totally right. There has to be a just culture component to this. Just saying this person did it, it's their fault is not adequate. And we will talk a little bit more about just culture later in this meeting. But you do have the chance that, say, the same person is making the same mistake. There could be, and when you go back, there was a training issue. So that is still a system error, but if they were not adequately or appropriately trained, then that's something that we can adjust going forward to make sure that that person is trained and everyone else is. So I think this is really important. All right, any other comments on that one? Okay. So number 3. So, and just, there's a lot of questions today. So just everyone jump in. Don't feel shy or you have to wait. That we're going to have a lot of discussion. We're making up for all of the presentations that we had before with our discussion today. So should the QA report include the type of error? For example, patient received the wrong medication, the wrong directions were provided, wrong prescriber, etc.
Nicole, it's Jesse. Yeah, I absolutely think that the type of error needs to be reported. Again, it gives you a more full picture about patterns that might happen. Also, just severity of error. It's a really important component, I think, of documenting errors.
Thank you, Jesse. Jig.
Yeah, I 100% agree with Jesse on that one. It's required and it's very important.
Thank you. Sung, did you have any feelings on this one?
Yeah, I just want to say yes, but I feel like my silence could be just yes. So
okay. Got it. All right. Yes, I completely agree. Again, I think one of the themes through all of this is that we're looking for patterns. When you're looking for just culture and systemic problems, you're looking for patterns. If you're seeing the same thing happening again and again, then that points to a systemic problem and not something that's happening at the individual level. Kula, I don't want to leave you out. I know you're a licensee member, so you may not have as many strong opinions on this, but did you have any feelings on anything so far?
Yeah, I mean, I think it definitely makes sense to be able to say, what is the type of error so that we can just basically, like Jesse said, we can see patterns and then, kind of intervene accordingly after we find out what those patterns are.
Great. Okay. Thank you. All right. Next question, number 4. Should the volume of workload completed on the date that the error occurred be required? I know you all have feelings on this one.
Yeah, this is Jesse. I think it absolutely should. I think it may take some work to figure out how to quantify that. If it's like the number of prescriptions being verified, it's going to be different by setting also, but also when you think of an outpatient setting or a setting in which there may be patient care services too. So I think that it may take some work to figure out exactly how to quantify that, but I think that is an important aspect. And going along with that too is, with, I'm sure, I think it's a future question, but just if someone's working alone, for a specific volume, that definitely changes the dynamic and the workload that one individual has.
Great, thank you. Anyone else comments on that one?
Yeah, I mean,
Go ahead, Kula. Go ahead, Kula.
No, I was going to say, yeah, I mean, absolutely that. And I just hope that if we start to, it's one thing to collect the data and have that, but then when the data tells you stuff, then what kind of action can we do, right? So I hope that, if it's showing that errors are made and there's an increase in work in, volume, that, there's some kind of, I don't know, intervention, right? Because if you just know, but then you don't intervene. So I just kind of want to caveat that.
Yes, absolutely. Some?
I just want to add, I feel like absolutely. So just with a caveat that, I know our committee's discussion have been, and kind of for the reasons we all know why, is been focused on community pharmacy settings. But then I think we also need to be mindful that we should consider how this would be relevant for like inpatient settings or long-term care settings and other settings. Because as far as I know, they're still required to have a QA review process for any medication errors or any errors. So just adding in there, I think, but absolutely we should have a volume for a community pharmacy setting, just a standalone community pharmacy. It's quite easy for us to conceptualize, I think, just based on the day that whenever this happened, please go back and look. I mean, I think that computer systems are advanced where you should be able to look back at how many prescriptions and whatever pertinent information. But for inpatient hospitals and whatnot, it may get a little tricky. So want to make sure that when we develop any regulatory proposal we might consider next meeting, we will have some language to have a way around those other situations.
Great. Jig?
I agree with everyone. And one of the things that comes to my mind is to really have a meaningful result out of that is to get other factors. So yes, if there's a question, how many prescriptions were filled in this pharmacy that day, it can vary from 30 scripts to some pharmacies. I know they do like 6,000 a day. And how many pharmacists worked, how many technicians worked, clerks worked, interns, all of that would give us a meaningful output, which is number of scripts filled by person per hour or something like that, right? So that then you can say, okay, what the workload was for the day per individual. Also, I know that there are lots of central filling and other where not every script per se that was dispensed out of that pharmacy was probably filled in that pharmacy. So that would also play a role, right? Because if there are 200 scripts and 60 of them came from a central fill, then the staff was only responsible for taking care of 140. Then robotics. That also plays a role. So, what are there? So, to what I'm trying to get to is to really answer this question, workload. There are other factors that would be very important, and that will need to be added to get an accurate result of exactly how much workload an individual had for the day to take care of their job that day.
That's a great point you're making. It really is. That's a great add-on. And 100 prescriptions, not 100 prescriptions, not 100 prescription. That's a great, really good point.
Yeah, Totally agree with that. I also, just to kind of touch upon what Sung mentioned, I have friends who are pharmacists in California, inpatient, who have verified over 1,000 prescriptions in a single shift. So when we're looking at that volume, that sheer amount of volume, no matter who you are and how long you've worked, you're going to experience some fatigue at that point. And kind of going along with the date of the error, I think the time of the error is important too. Like, did this happen towards the end of a shift where someone may have been exhausted, or did this happen during the busiest time in the pharmacy? All of those things really come into play when you're talking about volume and workload.
Great. Yeah, we're touching on, this is really great discussion. We're touching on some of questions that we didn't even have in here, but might be things that we can consider as we're going forward, like the setting and these other factors. So the next question that we have is, are there standardized items that should be captured, such as prescription volume, immunizations provided, et cetera? And I think we hit on this question number 5 a little bit in that discussion. And we can add on if you all have any other comments, but my thought is that we're all feeling like, yes, there needs to be an understanding of what kinds of actions were happening, what kind of services were being provided, not just strictly prescriptions.
Absolutely.
Yeah.
I think what might be hard for us though is, do we need to be specific to say, list all the things? Because that could be a lot of things. So, it's the challenge of CCRs or regulations is sometimes the details are good, but then it really has to be specific. And so, we don't also want to leave out something that may be important. So that may be a little challenging, but I hope that we'll navigate through as we have some more language. But I think, yes, we should absolutely. What will need to be, we probably have more discussion that will come about later.
Sure.
Yeah, I agree with Sung, because there are some, non-clinical services, especially in a community setting, that could be contributing to increased workload. If you're going back and forth from the register and you keep getting interrupted when you're trying to verify, or you have to keep answering the phone, those are kind of these clerical duties that aren't necessarily clinical, but could be contributing to distractions in the pharmacy. So maybe keeping it a little more vague or open-ended so that people can add contributing factors to the workload that day, which may be difficult for people to do looking back once they discover an error, but might be useful.
Jig, I think you were going to jump in. No? Okay.
No, I sorry, I left myself unmuted. No, I didn't have any comments. I think everybody said what they had to, and it makes sense.
Perfect. Yeah, so it sounds like I think where this came from was a lot of the feedback that we got specifically around, say, immunization. So it sounds like we think that maybe there needs to be some accounting for these types of items, but a little bit of space for it to be personalized to the setting, because understanding that it might be different. Does that kind of capture the idea of what we're talking about? Okay, I'm seeing head nods. Okay, question 6. Should the number of staff and their classification present on the day of the error occurred be required?
Yeah, I think we already kind of touched on. I think this is very important. And what would help probably is kind of just to understand what Jesse brought up is great, is about this. We need to look at why, what's the cost, obviously I think we know, but like we kind of need to figure out what's the reason for all of us getting so distracted. And there was an article which I think we might touch on our next section on medication error. A pharmacist working alone. I mean, it's an old study. Pharmacists working alone had a higher, I think, chance to make an error because they keep getting distracted or something. So just very important for us to kind of figure out and understand root cause of why things happen.
Anyone else? I think we did touch on this a lot, so. Okay. Next question, number 7. Should requirements be updated to require documentation of the actions taken as well as the dates that those actions occurred?
So this is tricky for me because the timing of QA review, by the time you're doing QA review, like, are we expecting the time to have passed that much? I mean, I guess it really depends. You know, nothing is black and white. I think we all know that. So it would be good to require documentation if available, but, you know, sometimes, you know, you're doing a QA review that just happened the day before, and then it doesn't require anything much other than to say that that's that. There's, you know, it could be a minor thing. If it's a severe thing, yes, maybe it's good to have that. But I don't know how I feel about it being a requirement, because things get a little dicey there. But that's just me.
This is Jig. The whole purpose of QA and, you know, what I call root cause analysis of an error is to have a conclusion of this is what happened, these are the folks involved, this was the, you know, workload for the day, and what are we going to do so that this type of error or other errors relating to that does not occur in future. So, and that would list, you know, 2 or 3 steps that the PIC and the staff and, you know, will take. And, you know, it could be, you know, further training or, you know, move the computer screen closer so you can see the pill image better or whatever it was, you know, that's concluded. So let's say if something else of similar nature were to happen and the steps listed are not really implemented, then, you know, if somebody writes the same conclusion that we're going to do this better, but, you know, there's no pattern of change, then it could be detected. So I feel that actions taken, that step is important and it should be noted on the QA form.
This is Jessie. I agree. I think, I mean, maybe if we incorporate it as part of the QA review requirements, I do think it's important that pharmacists are going through that review thoroughly and actually being aware of patterns. And I guess this may not be a question for us as board members, but I'm curious if, you know, with the development of this committee, do we know if reviewing QA forms is a standard part of the inspection process at this time?
And do you want to speak to that if you're able to?
Yeah, so
Sorry.
Can you hear me? No, that's okay. Can you hear me?
Yes.
Yeah. Okay, great. Sorry. So Jessie, yes, depending on the type of investigation, typically, you know, the inspector will look to see if there's any QA reports. I would say that we probably find some trends where a lot of maybe errors are handled through a huddle or additional training kinds of things. When we're doing some kinds of investigations, you know, because the duration, the records retention for QA is a year, they're not always available because of that records retention schedule. So I hope that was helpful.
Yes, thank you. That is helpful.
Great. And yeah, just to add on to what, you know, what Jig was saying and this conversation as a whole, if we're looking at just culture, a huge part of that is what are the outcomes? What did you do? And moving towards accountability. So if that's the way we're headed, I think, at a bare minimum, we should be looking at what the actions were that were taken and the outcomes. Because again, if you're seeing the same thing over and over again, you're not taking meaningful action. So the next question 8, should the board standardize the QA form? And there's a note on the screen here that the staff note that the information varies greatly between pharmacies, and we've kind of talked about that, like how would this look for different settings? And I will tell you all that this was a question that I raised, is if we should standardize it, because I think for some people, having to completely develop something from nothing is hard and overwhelming and leaves them, kind of stuck because they don't know where to start. So I'll leave that there and then open it up for discussion. What do you all think?
I mean, I'll say absolutely, because if we're also trying to reduce their workload and their stress, then let's come up with a standard form for them to use. And then also when we're making our data and analysis, reading through it, it's all on the same, like we're collecting the same thing from everyone. So I think it's kind of, I think it makes sense.
Thanks, Kula.
Absolutely. I mean, this is the reason why it's a little bit related, but not related. I think it is related, in my opinion, why we decided to have a PIC training and attestation, hoping that PICs would understand and aware. At this point, if we were to do a survey of all the PICs in the state of California and then ask them, are you aware of these QA requirements? I'm not sure if all of them would be really, be aware. And so because the QA process is not as, it's just just not as clear as I think we should be. So we should make it clearer. We should make it easier. We should make it simpler so that it's documented and actually be useful, not just a part of something you have to do, but something that you can do to make an improvement and make a difference in your workflow, whatever it may be. And hopefully, our corporate colleagues and the owners and management would actually take it seriously and listen to it and try to allow that kind of changes to happen.
Sure. And maybe there's and I don't know, I'm just talking out loud here. So I apologize, Anne and Eileen, if I go beyond what we can actually do, but perhaps we have like an example form for people that has the minimum things that are required. So if someone wants to go beyond that and add additional items, they have that space to do it, things that are more relevant to their practice setting, but that we would have something that's like, this is the minimum of what you need to do. Perhaps it's something like that. I don't know. Any other comments on this one?
This is Jessie. I agree. I think a QA form should be standardized. I would be interested. I was reading through these questions and I don't even know what this would look like, but I would also be interested in seeing like ways in which pharmacies identify at-risk behaviors or patterns. For example, if we notice that someone may be bypassing a safety process, whether it be putting medications in one basket if they're one family versus not using a basket at all, or having separate workspace for each patient so that bottles don't get mixed. It would be useful, I think, for there to be some corrective action for at-risk behavior that didn't necessarily lead to an error, but could potentially in the future, kind of like a preventative sort of thing. So I don't know if that would even be possible as part of a QA form, but that was just something that came to mind reading through these questions.
Dick?
I like the idea of having minimum requirements of a QA form, and institutions and companies, if they want to have more elaborate version of their QA that could include other supporting documents, that's perfectly okay. just providing one standard form would create would probably eliminate some of the other additional steps that some of the institutions might be taking right now. So I feel that just some basic requirements and leave it at that, and then everybody can modify their QA forms accordingly. And maybe an example for if somebody's starting a brand new independent pharmacy, they have something that they can print out from our website. So, and they could use that form as an example form. But minimum requirements is what I'm leaning on.
Great. Thank you, Jig. And yeah, I think, Jesse, kind of what you're getting into is like near miss and at-risk behaviors and catching them before they cause an error, which is obviously like, that's what you want to be moving towards with Just Culture, with, having a really robust quality assurance program. You want to catch things before they happen. So I really like that. And I think that would be, kind of next step for people who really wanted to go above and beyond, is kind of looking at that data. Anything else for this one? All right. Question 9. Should a threshold be established after which a specific number of medication errors occur or some sort of additional action is required? And the example given is if there were 12 errors in a 1-month period, and then the pharmacy may need to complete the ISMP self-assessment tool, engage with a consultant that specializes in medication error, etc. What do you all think?
This is,
I guess
go ahead, Kula.
Yeah, I guess my question is, are all errors created equally? And so, like, and again, this is me, just so I don't know, but because if we just say like a certain number, but then maybe there's more egregious ones. So I guess that's more of a question to help me answer this question.
That's a very good point, Kula. And there are, again, depending on the quality assurance program that people have, there are like rating systems. So you can rate errors like, again, on how egregious and dangerous they were. Like, for example, if you catch an error that never actually got to the patient and you document that, that's going to be different than the patient that got to the error, than an error that got to the patient, but that they didn't actually take. And then an error that got to the patient and they took the medication, that's a little bit more egregious. And there's a whole like scale of that. So that is a really, really valid question.
So I guess I'd want to base more my answer then on not just a flat number, but like on like the type of error, like a egregious error, that happens in a certain amount per month, and that would be flagged.
That's a really, really good point. Like maybe one super egregious error is enough to trigger this versus 12 others. Yeah, I see what you're saying.
Especially if you take into account also the volume. So let's say you have like this high volume, right? And then there's an error that is like that doesn't get to the patient, but that is caught right in-house. So then to me, like that's different then, right? So.
Yeah, good point.
My also another concern is that a pharmacy that's doing 6,000 prescriptions a day, they're gonna have, if there's a number, I am really not a fan of cutting numbers into like saying, oh, above this, doing that, below that, So I think there's got to be a better way to make this more useful. I'm thinking more like this just should be wrapped into discussion we will have next agenda item, medication error. Just kind of maybe leave it up to the staff. But yeah, I'm not sure if the number of error triggering something is that I see the point, but I just don't know how we can implement it to make it really useful, to make sure it's fair too.
Sung, how would you feel about it if it was a percentage? So if it was based on whatever your volume is, if you go over a certain percentage.
That's a
Does
good
that make
idea.
more?
Yeah, that would maybe, but then we're now having a pharmacy calculate like how many prescriptions they done in the last month, and oh my goodness. So, we just wanna help them stay safe, be able to, reduce medication errors, and but more to discuss, I think, on this question.
For sure. Jig?
Yeah, I'm not supportive of putting a number just based on all the reasons Kula gave and Sung gave. I don't think that we can. It's a very complex to exactly come to a conclusion for the next step. But I feel that robust QA process, as we had discussed in the other questions that we all answered and made comments on, if that's done sincerely and the actions taken and everything else that comes out of it, the learnings, and I think that can prevent errors from happening. And that's our goal, is to protect the consumers, and I think that will suffice. Um, in some of these steps, if that's needed, I know that the board can suggest that this is a resource for anybody that want to take that extra step to ensure that then they are doing everything possible to prevent any errors from leaving the counter. But yeah, I'm not in for putting a number to it.
Sure. Jesse?
Yeah, I agree. I think even the percentage thing would be difficult just because of what Kula was saying, that all errors aren't created equally. Someone who received a medication and ended up in the hospital, that error is not the same as someone who was shorted 5 tablets of a medication. And so it would be very difficult, I think, to establish a threshold. I don't see how it would necessarily be possible to put into something that, yeah, I mean, just thinking about how to create it, I think would be a very difficult task.
Sure. I agree with you all on the difficulty, though I love the concept of having this, because if we're seeing excessive, errors, it's like, I love the idea, although technically if you're doing it right, kind of to Jig's point, you should catch that yourself and start taking action. So this one's a little bit tricky. I love the concept, but execution seems very, very difficult. All right, next question, last one for this section. The current records retention schedule is 1 year. Should this be extended?
I'm going to jump in and say absolutely. This should be 3 years at the minimum. Absolutely. No question. Sorry, I'm being very, yeah, this actually should be made. Yeah. So anyway, sorry, that's just it.
This is Jessie. I agree. I think when we're looking at errors and we're looking, I guess this is specifically in a community setting, there are times in the year that we know the volume is going to change. So that's going to be during flu seasons. Also when COVID boosters come up, the demands in the pharmacy change. Also, the weeks leading up to holidays are another good example. And so we need to figure out ways to actually see those patterns long term. I mean, truthfully, I would say 5 years is probably going to give us an even better picture. And then when we're thinking about a staffing model, if we're noticing that these errors are happening during those busiest times of the year, that's when the pharmacies can start to evaluate, okay, well, maybe we do need to hire more staffing during this time of the year, during XYZ. So I absolutely think it should be extended.
Great. I agree. You have to compare data year over year to see how you're doing. So if you only have 1 year of data, you can't really adequately. So I don't know exactly. I don't feel as strongly about a number, but both 3 years seems a minimum to me, and I think 5 years sounds really good if you're really trying to look for data and patterns. But yeah, I think Jake, did you have something to add?
Yeah, I think extending it from 1 to 3 would be more pragmatic, because sometimes error could have happened like 6 months ago, when the original prescriptions was filled as a new one, and then subsequent refills, right? So it's already 6 months in, and so if this requirement is based on when the error happened, then within 6 months of filing the QA, that could be shredded. So yeah, I think 3 years would make it more relevant.
I have a question, actually. This is Jessie. Sorry to interrupt, Nicole. Do we know what the discipline, like its threshold is for, say, like there was an error that we found years later that was reported to the board, and it was investigated? I think it makes sense to have longer record retention, only to have more information about contributing factors to that error. Is there like a threshold there, or maximum length of time?
And sorry,
you want Anne question?
No, yeah. I don't know if can you hear me okay? Sorry. So Jesse, as I understand your question, I think you're asking, is there like any kind of statute of limitations or something along those lines? I am not aware of anything. I would say that it is not uncommon for the board to find out about a medication error through a settlement agreement. And so under the law, settlement agreements that I believe the dollar threshold is over $3,000 need to be reported to the board. And typically by the time that settlement agreement has been reached, it's well past that year. So when contemplating, this policy question specifically, I think it's possible that a settlement agreement could be even outside of that 3-year window before the board would be notified to conduct its investigation.
Got it. So it might be helpful going forward if it was possible to get a little more information about what those timeframes look like if we're going to consider something like that. I don't know, Anne, if we can get that, but that might be helpful to understand.
Yeah, so we could probably get some information, Nicole. The only thing that I would say is that it might not be totally reflective of what actually happens. I'm not sure that the board receives all settlement notifications. Do you know what I'm saying? And then when the settlement happens and when we get notified may be different. So we can pull some data definitely and provide that, but I just want to, I guess, caution that it might not be telling the full story.
Sure. It would probably just be helpful in general for us to because there's oftentimes even in investigations, there's a little bit of a delay. So I think it would just be helpful for us to know generally what length of time would be useful for the board inspectors. What length of time would kind of make sense for the work that we're doing would probably be helpful for us to know. Great. Did anyone have any other comments on this one? All right.
Sorry,
then
Nicole, can I ask?
Yeah.
Sorry, this is Anne. Could I just ask, so how does the committee feel about maybe requiring some sort of like aggregate data before the QA is, whatever the time frame is, but should there be, some sort of like aggregate data, where there's standardization to maintain that for historical? Sorry, I didn't mean to interrupt. Just wanted to know where the committee is on that piece.
Perfect. Thank you. Yeah, I totally did not read that part of the question. Thank you.
I think that is very important. Yeah. Yes. That's all I can say. But I don't know how you would quantify it, but that's, because quantifying the QA is not simple. So that's my a little struggling thought there. But yes, I think we should figure out a way to try to come up with some way to aggregate it. Just like how ads, I think, are supposed to aggregate the quality assurance reports at their renewals. So anyway.
I like the suggestion as well. When you're looking back at your data and again, looking at how you're doing year over year, that data is really helpful. Anybody else? No? Okay. Thank you so much, members. That was a really great discussion. I really appreciate it. Moderator, can we please go ahead and open the line for public comment?
This is the moderator. At the direction of the chair, I've opened up the Q&A feature for public comment. Members of the public, if you would like to make a comment on this item, please click the Q&A icon located at the bottom right-hand corner of your WebEx screen or use the raise hand function. Audio-only participants can raise their hand by pressing *3 on their device. And it looks like we do have a couple requests for comments, so I'll go in the order that they're received. Our first one is Ms. Gruwal. Ms. Gruwal, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Good morning again, Chair and committee members. Thank you for allowing me to make public comment on this item. I'm going to be a little all over the place because there was a lot of questions and really great discussion, so appreciate all the feedback that was shared by the board. On question number 2, I thought the question, instead of asking which staff was involved in the error, really thinking about who was on staff, the different types of shifts. Were they a tech? Were they there for a couple hours, a whole shift, 12 hours, and then how many days they continually worked leading up to the med error is really important to look at. So making sure we're assessing what staffing was appropriate at the time and played a role in the error. On number 4, agreeing on this question, to really looking at the workload and the volume of the pharmacist, seeing if they were overworked, overwhelmed, and not just the volume that day, but the volume leading up to that med error, I think is important because we know that pharmacists, if you're working 4 12-hour shifts, you're being continually burnt out over those days. So how many days were you working leading up to that med error? On number 7, really important to be able to document the actions that were taken, but also what actions were taken by the employers after the med error to prevent any future med errors, and making sure those actions were actually having the intended effect that they were wanting. And if med errors are continuing to happen, what needs to be added to those actions to make sure that that is prevented in the future. So we have something that we're documenting that was taken, and then being able to enforce against that and assess if that was the right step or not. On number 9, question number 9, I think it is important to look at if there is X amount of med errors that are made, that additional steps be taken. I hear the board's comment on the varying errors of medication errors. So I think that is important to look at, but also making sure we're capturing not just I know this, and later in the agenda, we'll talk about just different components of med errors, but looking at close calls of med errors. So was somebody chasing after a patient? Were they able to catch it on exchange with the patient or during consultation? So capturing the med error, but also the close calls that were happening. And I think that there are larger pharmacies or smaller pharmacies, but a med error is a med error. And so that patient that was harmed, even if it's one, that's one too many. So I think it would be worthwhile for this board to look at how we can get some sort of quantifying to make sure additional steps are taken when a pharmacy is consistently having varying med errors. And then for the last question, really urge the board to extend the retention schedule to 5 years. I think there was great comments made by 2 board members about how we need to increase that, but also want to align that with the new citation authority that was given to the board that looks at citations over the past, or violations over the past 5 years. Thank you for allowing me to make comment.
All right, this is the moderator. We'll move on to our next individual who has requested public comment. John Gray. John, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, good morning. This is John Graham, a registered pharmacist with Kaiser Permanente. Thank you very much for the opportunity to provide comments today. Just first, a few comments on the items that the board discussed. First, item number 8 relating to standardizing the QA form. Just want to advocate for the kind of position that Board Member Patel and Committee Chair Thibault discussed around providing minimum standards for the form or a sample form while not mandating a specific format or type of form, just recognizing that different pharmacies may use different commercial systems to perform this function, may have homegrown systems to perform this function. I think maintaining the flexibility for pharmacies to select the system of their choice as long as it meets the minimum requirements would be preferable. Second, on question number 9, related to a threshold after which certain actions need to be taken by the pharmacy. It sounded like largely the committee was kind of coalescing around some significant barriers to doing this. I would also just point out, I don't think this was discussed, that the quickest way to get people not to report medication errors is to punish them or make them do something in response to medication errors. So I would just caution the board that if it requires a pharmacy to say do something after X number of medication errors in a month, the quickest way for the pharmacy not to have to do that is just to not report medication errors. So I think that could be a major concern with that approach. Then just a couple other things to consider related to 1711 more broadly. 1711 Part E mentions, a record and the record of quality assurance. As you know, sometimes reviews of medication errors can take a while. And so what we'd like to see the board consider is the flexibility for quality assurance records to be maintained kind of in multiple forms, or, one error requiring quality assurance may have, a form, but also some ancillary documents. And so we think that the regulation should clearly specify that the board that a pharmacy can maintain ancillary documents related to investigation of an error. And then secondly, we would recommend the board allow for a longer implementation timeline, as pharmacies will need to update their error reporting and tracking systems in response to changes to the requirements that be documented. Thank you so much.
All right, this is the moderator. I'll move on to our next individual who has requested public comment. Let me find them in our attendees. Rajan Vaidya, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Can you hear me?
Yes, we can hear you.
All right, thank you so much. Good morning, Rajan Vaidya from the California Pharmacists Association. First of all, appreciate the conversation that's been going on with quality assurance. In line with CPHA existing policy, CPHA definitely does support pharmacists being involved in the development and operation of continuous quality improvement programs to improve quality of healthcare. Now, a couple points and a couple discussions that were made, and just to echo some of the sentiments that the committee members were discussing. First off, with the staffing names and being added into the report, as committee member O and Carly kind of mentioned, having specific staff names may detract from organizational changes that are occurring. So just some concerns regarding how that may be collected. In addition to that, the volume of workload question and how you would define workload. I think the committee did a great job of discussing that. And committee member O, thank you for bringing up the point of different healthcare settings and pharmacy settings and defining what that may be. We may need a broader definition of workload rather than a community-focused workload in some of these forms. And having that balance between collecting qualitative and quantitative data for that volume of workload, right? So making IVs in an IV room would be a very different kind of impact versus, maybe verifying prescriptions while you have phone calls and other things going on. So ensuring that we have that quantitative data, but also looking at the qualitative approach of exactly what amount of work and clinical awareness that may be needed in certain areas. In addition to that, the conversation regarding the error threshold, from CPHA, we'd be a little concerned with requiring a error threshold, but rather in keeping in the spirit with continuous quality improvement, looking at overall trends over months or years to see that the same types of errors are not occurring over and over again, rather than having a number that's put in. And then Chair Thibault, your comments regarding a standardized form and the minimum requirements definitely support that. And having a sample from the Board of Pharmacy would be really helpful in different settings. So different settings are able to really share the intention of this, which is making sure those errors don't happen in the future. So definitely wanted to echo the sentiments there. One point of reference that may be helpful for the committee members and the board to consider is there is a nationally recognized by the Federal Agency of Healthcare Research and Quality program of HHS. There is a patient safety organization called the Alliance for Patient Medication Safety that does a lot of this work already and may have some of the content in terms of minimum requirements and the best patient safety organization, continuous quality improvement forms that may be used. And full transparency, I am on that board, serving on that national board, but that may be an organization to contact, so that way the Board of Pharmacy doesn't have to reinvent the wheel on the form itself.
All right, this is the moderator. It appears that was, I apologize. We have one more request for public comment from Lindsay Gullahorn. Lindsay, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Good morning, Chair Thibault and committee members. I think I'll focus a lot of my comments on the next agenda item, but I did want to echo what Rajan just said about patient safety organizations. I think it would be really beneficial for the committee to hear from a PSO like ISMP, or maybe the Alliance for Patient Medication Safety at a future meeting. APMS specifically is a PSO that works with pharmacies, independents, chains, and others. And I think the main reason this would be beneficial would just be for the committee to hear from a PSO about the concept of how all of this information is reported to them, what the guardrails are and what the requirements and prohibitions are and what pharmacies can and can't report. There are a lot of federal patient privacy requirements and limitations on what can be reported. So just encourage the committee to perhaps hear from a PSO at a future meeting to learn more about what they do. Thank you.
All right, this is the moderator. Appears that was our last request for public comment. Would you like me to close that Q&A panel?
Yes, please close the panel. Okay, thank you so much. And thank you to all our commenters. I appreciate you taking the time. Members, given the public comment, do you believe we should be reconsidering any of these items? Okay, Jick, did you have something?
Yeah, I'm more curious to know about PSO and the role they can play.
Sure, maybe that's something that we can look into having a presentation in the future, Anne, if that makes sense.
Yeah, so we have had ISMP give a presentation, so we could check into perhaps them coming back if that's something that the committee is interested in. Happy to look into others as well and look into whether or not any of what the committee is contemplating would violate patient safety issues. I don't know that we've talked about recording anything at the patient level, but happy to look at that as well. And then we did have one template from ISMP included in the meeting materials, but I can look at the other ones as well.
Great, thank you. Any other member comments? All right. So thank you, everyone. As it appears, we believe changes may be appropriate. We will continue our discussion at our next meeting. In the interim, with the feedback we have provided today, staff can begin developing a proposal for future consideration by members. So before we move on to agenda item 5, I need a little break. I think probably some of the other board members too. How long do we want to take? Like 5 minutes, 10 minutes? What works for you all?
I say 5 minutes.
Okay, that works for me. Is that good, everyone?
Yep.
Sounds good.
All right.
That works.
Perfect. Thank you. So see you all back at 11:17. To see if everyone is back, I'll do a roll call vote. All right. President O?
Hi, Nicole, I'm back.
Hi. Jesse Crowley?
Hi, Nicole, I'm here.
Thank you. Kula Koenig?
I'm here.
Thank you. Jig Patel? Jig, are you here? I see you're off mute.
I'm here. Sorry, thanks.
Great, thank you so much. All right, so we have a quorum and we can get started. So agenda item 5 is the discussion and consideration of medication errors and possible future development of medication error reporting requirements, including use of required standardized reporting. Members, as indicated in the meeting materials, the reporting of medication errors is voluntary and there are various sources that accept such reporting. The issue of medication errors is not new. A study referenced in the meeting materials back from 2003 concluded that dispensing errors were a problem at a national level, with about 4 errors per day and a pharmacy filling 250 prescriptions. In addition, the New Hampshire State Board of Pharmacy reviewed medication errors it received between February 2007 and July 2012 and published its results that include 40% of the errors involved dispensing the incorrect medication, and 68% of the errors occurred when only one pharmacist was on duty. Limitations on the results included that the reporting of errors is not mandatory. The practice of pharmacy has changed over the years. Such changes include pharmacies that may have integrated in technology in the dispensing process and expanded authorization for pharmacists. More recent information published suggests that about 1.5% of all prescriptions in the community setting have a dispensing error. While that percentage sounds low, given the number of prescriptions dispensed in California, the estimated number of dispensing errors is staggering. Members, as we discuss this issue, again, there are questions included in the meeting materials and displayed on the slides. As with the last agenda item, we will begin discussing these questions as a committee. Following our discussion, I will open up for public comment. So our first question, should the board establish a requirement to report medication errors?
I'm gonna jump right in. I'm sure this will be controversial, but I do believe if we don't know what's going on, we can't fix it. And I'm going to emphatically support and recommend that we actually do require it. It's time that we really need to have an understanding. Because if we say something's wrong, the excuse is that it's anecdotal, it's not widespread, and that it's not happening because there's not enough data, and then they'll say there's no data. So it's gonna have to start somewhere, and I think we're gonna have to start it. So that's where we are. I am open for discussion.
Thank
Hey,
you.
Sung,
Jesse?
Yeah, I completely agree, Sung. I think we need to have a med error reporting system. What that actually looks like, I think, is going to be complicated to figure out, because I do want there to be there to be some sort of protections for pharmacies and individuals, and some sort of anonymity if we do sort of reporting. For example, though, maybe we get trends that several pharmacies across like one corporation or one chain are having several errors. And so we can see a pattern that may be systemic within that organization. But it may be a little bit difficult to have some anonymity if you have like an independent pharmacy reporting errors. But I do think if we are really committed to figuring out how to address medication errors, we need to first start by collecting data.
Thank you. Jig?
Board is right now enforcing the QA part of it. We take all the consumer complaints, and whenever that is looked into details, all of those documentation of errors, etc., are collected and looked at. So there is an oversight. There is a requirement of the QA that pharmacy is supposed to do. Incident reports, that's all the pharmacies are required to file all the errors, and board enforces that. Now, sending and taking a look at and data mining every single incident that happens in thousands of pharmacies that are licensed by the board, that's going to be a monumental task. So I don't know. I mean, looking at the cost of it, the logistics of it, it seems like that's going to be a lot of work. So there is an alternative in place right now. So what I'm saying is like, let's not reinvent the wheel on this one. So I don't think it's required. Mm-hmm.
Thank you. Kula, I'm not sure if you were speaking, if I cut you off, or if that was Jesse, I'm sorry. Did you have anything to add, Kula?
Yeah, I mean, I think when I just been thinking about also just independent pharmacists, and I don't know if like this kind of stuff puts more pressure or onerous, makes it harder for them. So that's just, I don't know how valid that is, but that's just something that was in my head. But I do think, like Song said, it is important that we do it. But I just think about the burden of additional requirements and reporting.
Great. Thank you so much. I think I get the concerns about how tough it is, but I think we can't tackle a problem that we don't fully understand. So I'm going to lean towards yes, we should, but that we have to find something that isn't super difficult. As Jig was saying, we have to use something that already exists, not reinvent the wheel. And I love, Jesse, you brought up anonymity. I think that's going to be really important in this process as well. Any other comments on this first question? Okay, question 2. If we believe such a requirement is appropriate, what entity should receive the reports? For example, ISMP would, and I think this is kind of getting to what you were talking about, Jig.
For me, this is Song, I think we need to start simple, so not to complicate too much. So I'm not sure if any entity should get it other than just us. But I'm going to defer to Anne on her thoughts, because I mean, if we do go ahead and go with this, that implementation of this will be enormous, as Jake said, and it is definitely a concern.
I think it's hard to totally anticipate what the impact would be. If we develop an interactive form on our website that makes it ideally streamlining for the, for the entity that is filing it. And then, the data is aggregated in the back end. It might not be bad. I think it would probably depend on, what those elements would look like. So it's a little bit difficult to say at this point, but again, it's the policy is for you all to determine, and then we'll figure out at the staff level how to make it work if you determine that the board should be the one to receive it.
Jessie?
Jessie, yeah, I think it should be the that receives it.
I would be interested in learning a little bit more about the pluses and minuses. I'm leaning towards an external organization because I feel like people would be more apt to report if it's not going directly to the board, if we want them to. And I also love the idea of ISMP getting all of that data in addition to what they already have and being able to use that on a really large scale. And I think they have the tools for it, but I'm not committed 100% one way or the other. Jig, did you have a comment?
Yeah, I mean, patient safety organization, PSOs, like CPHA had mentioned. I'm thinking that could be compliant, and any necessary data that's required could be extracted out of them without the staff having to do all that. So I'm leaning towards going external to one of the PSO and taking care of it that way.
I feel like, sorry if I just can, I feel that one, it's anonymous, right? So to that point of, people would feel if it was coming to the board, but it's going to be anonymous. So we're saying, and two, if we send it to a third party, aren't we going to get it anyways? Like, we need to see the information. So I guess I'm not sure like what is the difference of it's anonymous and it's going to a third party, but we still have to see the data. We still have to get the numbers. Anyways, I'm leaning towards us getting it.
Yeah, my thought was just that if it goes to an outside organization, it would take away any fear that someone had. Even if it's internal but anonymous, people might still be nervous about reporting it, again, because we're the body that regulates them. Whereas if it went external and they knew it was going to be de-identified before we saw it, that might add just a level of trust to the process. But again, I'm not really sure. That might be something we need feedback on, and maybe information about what the other companies can do, what these other organizations can do that we can't, or what maybe the cost would be to us, that sort of a thing.
Yeah, and maybe a presentation from a couple of PSO to kind of go over the data. I think it will shed light for all of us, and then we can make a good decision after learning all the intricate details of the reporting and how the board would benefit out of it, and eventually how the consumers would be benefiting out of reduced medication errors.
This is Jessie. Do you know how the New Hampshire Board of Pharmacy collected their data? It may be a good idea maybe to reach out to them and get information from a board that has experience collecting this sort of data.
Yeah, Jessie, I am happy to reach out and see, based on my read of it, it was not mandatory reporting, so they evaluated the information that they had, but I'm happy to reach out, absolutely.
Great, anything else on this item? Okay, question number 3. If we believe reporting should be mandatory, should the requirement be in place for a limited duration for purposes of conducting a study, similar to the approach taken in New
Um, this is a song. I think the concern is, just to do that, I think will require so much legwork for all the legwork. And then you just say, oh, okay, 5 years later, never mind. All the work we put in to make it happen. So I'm not sure where I am. I'm really not one way or the other on this question. I just have some reservation on if it's just temporary. I feel like we're gonna do so much work extra. I mean, obviously it depends on what we decide to proceed, but it just will be kind of wasted when we could possibly make this a continuous process improvement for our California patients by having this ability to collect data long term and hoping to show that it's reduced whatever it may be. I'm hoping it's more long term. If it's just for study, I still would be open to it as well.
Sure. What else?
Sorry, go ahead.
Oh no, I was going to say who else has comments. Go ahead, Jig.
Oh, thank you. I'm just thinking, state as small as New Hampshire is not requiring every single incident coming, because knowing the gravity of work there, it's a lot to take in, and that's why I'm leaning on a third party, PSO, and just let them collect it, and we call that compliant, and then we as a board can get summarized data out of that. So at the end of the day, we want the summary, what's happening, what kind of errors are happening, and so that appropriate regulations, if they need to be changed or edited, then that's how we could take steps. So that's, I'm still inclined towards that.
This is Jessie. I think, regardless if we have the data come directly to the board, which I am in support of, versus a third party, it's still going to be a lot of work. I don't really see a benefit of having it necessarily be just for a short time period, just because we can always just extrapolate data from a specific time, I would assume anyway, and I would hope. And so if we wanted to publish some sort of study, then we could do that while still maintaining the mandatory reporting in place.
I think I don't feel strongly one way or the other on this. I'm just like the last question. I feel kind of in between. I think there's kind of benefits to both. One is like, again, what is this going to cost, and how many resources is it going to take? I think if we look at maybe using an external company that does this, where they have the expertise, that makes more sense for it to be temporary, but possibly repeated. You do it, you make your action to try to change something, and then you test again to see where you are. That's kind of like the standard procedure. Although if we decided to do something internally and we found something viable, we could do the same process and just keep that data. So I think we feel something should be done. We just don't know the specifics, and I think we need probably a little more information about what this might look like if we did it versus of an external company, because it sounds like we're a little bit split, if I'm reading correctly. Does that sound right to everyone? I see head nods. Okay. Any other comments on this one? Okay. Question 4. Should the board establish a standardized medication error reporting form?
I say yes, in conjunction working with quality assurance. I mean, I don't think this needs to be complex. I'm hoping that, and also the process of it hopefully won't be too complex when we are hopefully proposing some CCR 1711 update possibly Maybe it could just be as simple as, all licensees shall report to blank, whatever that maybe we decide to do. And that, the form, whatever that QA that you have, you can just hopefully submit it. So it's not double work, but, details to be ironed out. But yes, I think we need to have some standard. And granted, understanding some comments, a lot of computer softwares that pharmacies use may have internal QA software system that they already have and the forms. So we don't want people to have to double work and copy and paste. But I think we probably will need some sort of standardized form to analyze the data. So sorry, I'm like saying both ways, but that's kind of where I am.
Sure, Jig.
So what's going on right now? Our current state in every pharmacy, every setting, incidents have to be reported and everybody have a system in place. Just like our QA form that should have some minimum requirements, I think a guideline to everybody to be compliant, where, I feel that 80-90% probably would be compliant, but the board can give guidelines on what are those requirements, and they can edit their current processes to comply with that, and that's it. I mean, I don't see we have to make it more complex or cumbersome than the solution could be very simple and easy.
I feel like either way, external organization or internal, we probably do want a standardized form so that we can look at that data in a really meaningful way. Because if people are just submitting all kinds of different forms, we're not going to be able to pull the data. I do feel pretty strongly, though, it needs to be simple and like a series of choices, probably mostly check marks. And then maybe there's a box to put in a little bit more information. But if we want this to be something that we're expecting everyone to do, we don't want it to be too burdensome. Get it to be like a one page and you go through and you click off certain things or just fill in certain boxes. It would have to, the technology would have to work really well, that it's not a super manual, difficult process for people, would be my thoughts. Anything else?
I actually agree with your thoughts, Nicole.
Great, thank you. Okay, so that was it. That was the series of questions for this section. So now, and thank you everybody, another really great discussion. I'm really enjoying this meeting. So we're gonna go ahead and open it up for public comment now. Moderator, could you please open the line?
This is the moderator, and at the direction of the chair, I have opened up the Q&A feature for public comment. Members of the public, if you would like to make a comment on this item, please click that Q&A icon located at the bottom right-hand corner of your WebEx screen, or use the raise hand function. And audio-only participants can use the raise hand by pressing *3 on your device. It looks like we have a couple requests for comments. So go in the order that they're received. First is Lindsay Gullahorn. And Lindsay, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. Good morning again. And I apologize. I don't think I introduced myself last time. This is Lindsay Gullahorn with the California Retailers Association and the National Association of Chain Drugstores. Just want to say that I agree with board members Thibault and Patel, and I think the use of a third-party organization like a PSO would make the most sense. By giving pharmacies the ability to report to PSOs, it would meet the goal of both ensuring that medications or errors are being reported and protect patient privacy, because the information disclosed to PSOs is done so in a way that safeguards patient privacy. I know that all of the information and data points that have been discussed earlier, they're considered facts of a particular incident, and those can be reported to PSOs. And while some of that data may not jeopardize patient privacy, other data that is reported to PSOs is sensitive, like what happens after an error occurs. So reporting to PSOs is actually probably a more comprehensive way to ensure that the necessary information is reported including actions taken by pharmacies after the error. And it's done in a way that prevents pharmacies from having to disclose this confidential info, which could compromise a patient's privacy. So also want to echo Board Member Patel's comments that requiring the board to take all of this information in and analyze it, that could be a lot of work. So definitely think that PSO is a good option to help ease that burden. Another thing, would like to encourage the board to look at New Hampshire. I think that's a great idea. New Hampshire's regulation includes a provision that basically says that if a pharmacy is reporting to PSO, they are compliant with the reporting requirements. So whatever direction you decide to go, I think utilizing PSOs and giving pharmacy that option really is overall the best way. And just to speak a little bit about what PSOs do, the goal of PSOs is to improve patient safety and reduce occurrences that put patients in harm's way, like medication errors. So the point really is to allow healthcare providers to report medication errors and confidentially share best practices associated with what was learned from those errors. So pharmacies that participate, they can track and examine patient safety data, which in turn helps identify patterns and insists in the prevention of errors in the future, which the board could utilize as well. So again, I really appreciate this discussion. I think it would be great for the committee to hear from a PSO, and I look forward to that in the future. Thank you.
All right, this is the moderator. Our next individual is Jessie Gruwall, and Jessie, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. Jessie Gruwall with UFCW Western States Council. Thanks for allowing me to make public comment yet again. I would agree with the board's discussion on mandating reporting. I think it's really important to be able to really assess what is happening across California's pharmacies. I think it's important to keep those anonymous so workers aren't deterred from reporting, and that we're actually getting a more accurate account of what's happening in terms of medication errors. I think it's also important as we represent community or chain pharmacies to also include the name of the chain pharmacy so we can see trends across each chain pharmacy, since they do have different operating procedures in those pharmacies, to see what is working and what is not working. From that data, we can extrapolate best practices, but also areas of improvement amongst those chain pharmacies. I think it's also important to require the board to do an analysis of the data and be able to release that to the public so that we know what type of efforts can be made on the outside to improve public safety within pharmacies. I would really oppose having this go to a third party where there isn't that transparency and openness that comes with the board and this board and board meetings, and really is seen as a closed off siloed entity to the general public and advocates. I think, Nicole, you said it best. We can't really tackle a problem that we don't fully understand. And so making sure we're having that reporting is so important. But in that reporting, if there's a way for the board to take in comments around our pharmacists citing staffing issues, workload issues, and being able to report that back to this board of what some of these causes for medication errors could be across different types of work sites. And then lastly, I believe that's it. Thank you. I appreciate you allowing me to make comment.
All right, this is a moderator. We will move on to our next individual, Rajan Vaidya. And Rajan, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you so much. Good morning to the committee members again. Rajan Vaidya from the California Pharmacists Association. Again, appreciate the conversation that's going on regarding medication errors. And to kind of echo Lindsay Gullahorn's comments, I think the use of a patient safety organization would help alleviate any concerns of reporting medication errors to a licensing agency that oversees the licensees of the individuals, but also the pharmacies themselves. The concern really is around the pharmacies themselves rather than the individual licensee, which most of this data will be anonymous, but there may be some concerns or distractions from individuals reporting medication errors when the pharmacy itself may feel like that data going to a licensing agency may be skewed in other ways, or maybe that information may be taken and actions may be taken from those data sets afterwards as well. So I think the patient safety organization helps create that barrier that's needed to focus on what the priority is, which is patient safety and patient outcomes, rather than focusing on where the data is being reported itself. I think it goes to the spirit of continuous quality improvement, as was discussed in the previous committee agenda item, but also ensuring that individuals themselves are encouraged to report that data, because that's exactly what we want to be happening. So thank you for that, and appreciate the conversation.
All right, this is the moderator. Our next individual is John Gray. And John, you'll be given 3 minutes to speak in a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, good morning again. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. Thank you again for the opportunity to provide comments. Just want to echo the comments of Chairperson Tebow and Board Member Patel, as well as my colleague Lindsay Gullahorn from NACDS. If the board wishes to establish a reporting requirement for medication errors, we believe that doing so through a third-party PSO is the best approach. At the July full board meeting, we expressed concern about the board's current approach to issuing citations and fines for medication errors. To me, it seems incongruous that an entity should be required to report medication errors to the board when it is likely that that board is then going to consider issuing a citation and fine both to the pharmacy and potentially to individual pharmacists involved in that error. So I think all of the discussion around reporting to a third-party PSO as a kind of buffer is valid and a preferred approach. And then the topic of the standardized form, obviously I think everybody recognizes that if reporting were to go to a third-party PSO or potentially even the board, whatever organization the report is made to will probably have its standardized form. I think what we just want to keep at the front of board members' minds is we would appreciate the continued flexibility for organizations to continue to use their own forms for internal documentation of medication errors, as long as they meet all of their required elements in 1711, and then just continue to kind of hammer away at the idea that if there are significant changes to those requirements, it may take some time for organizations to update their software systems for their QA forms to meet all of those new requirements. Thank you so much for the opportunity to provide comment on this very important topic.
All right, this is the moderator. Appears that was our last request for public comment. Would you like me to close the Q&A panel?
Yes, please. Great, thank you. Members, did you have any additional comments related to public comments or on this topic? No? Okay. Members, there appears to be a general consensus that as a committee, we believe additional requirements may be appropriate regarding the reporting of medication errors. Given that, if the committee is agreeable, I will work with staff to develop a possible proposal that could serve as a framework for our future consideration. Great. All right, we can move on to agenda item 6, which is the discussion and review of enforcement actions taken and enforcement authority exercised by other jurisdictions related to workplace conditions. Members, the next item for our consideration is enforcement authority exercised by other jurisdictions related to workplace conditions. As we learned during our last meeting, in Nova Scotia, legal provisions require that pharmacy managers ensure that staffing plan is commensurate with the needs of the patients of the pharmacy, and that when staffing issues are related to errors, the board can require the pharmacy owners and managers to show proof of how they ensured that regulatory requirement has been met. There are several other jurisdictions within the U.S. that are evaluating this issue as well, including some establishing requirements to report unsafe working conditions. Some have provisions to ensure sufficient personnel are scheduled to work. Some have notification requirements requiring a pharmacy to notify patients if the pharmacy is experiencing significant delays or cannot dispense prescriptions in a timely manner. In California, there are provisions established for when a pharmacist is at lunch, requiring a community chain pharmacy to ensure designated staff are available to assist a pharmacist when requested, as well as a new requirement establishing a prohibition on workload quotas. Including in the meeting materials are specific legal requirements for some other states. I don't intend to read the information as it is detailed in the materials, but I note that several states include a requirement for the pharmacy to ensure sufficient staffing. I do not believe California has such a requirement. Members, I would appreciate your thoughts on the information presented, including if you think some of the authorities in other jurisdictions should be considered as possible requirements in California. I would assume, based on our discussion, either statutory or regulatory changes would be necessary depending on our recommendations and subsequent action by the board. Goodness, I never knew I had such a hard time saying the word jurisdiction until you have to say it like 20 times in a row. So anyway, what are your all thoughts on this topic?
Song, I'll jump right in. I think that these are great. I'm glad. Thank staff for doing all the research. And I know Virginia was brought up quite a few times in the past meeting as well. Illinois' approach is very interesting. I think Oklahoma, I mean, honestly, all 4 states that are presented here have very good approaches, and I think we should definitely pursue whatever we think we can to pursue to change. I'm kind of maybe being daring here, but I think we could look at all of the possible avenues that they're all doing, and we could try to incorporate into our laws and regulations. They seem to be taking very common sense approach, not anything extreme. So I don't think why we can't follow their lead is, I think we can definitely not copy, but just look at most of them and see if we can implement it in our states as well.
Great. Who else?
Hey, this is Jessie. I agree with Sung. I think all of these states are doing amazing work in really prioritizing, research into staffing models in pharmacies. I think definitely something like Oklahoma, where we can actually have a inadequate staffing reporting form would be really great. I agree if we could kind of consolidate everything into one sort of policy for California, that would be amazing. I will say the Virginia law was very, very interesting to me in that they actually limit the amount of hours that a pharmacist can work. I do think a 6-hour rest period in between shifts isn't long enough if you're doing 2 12-hour shifts, but it makes me think of pilots and how they have limits on being able to work shifts. And in pharmacy, when you need so much mental energy, even doing a 12-hour shift, no matter who you are, you're just not at this verifying or working at the same level mentally at the end of your 12-hour shift that you would be in the beginning. So looking into potentially having limitations on working or mandatory rest periods between shifts, I think would be a very interesting thing to look into as well.
Jigs, did you have comments?
Absolutely. Yeah, I see some of the things that some of the other states have done. And, just segueing into what Jesse just mentioned, that, truck drivers can only drive for X amount of hours before they have to take time off. Pilots, same thing. And, pharmacist, again, 12 hours. Working more than 12 hours, I don't see how a human can be 100%, and being a pharmacist requires to be 100% for the safety of our consumers. So some of the things definitely needs to be considered. There are words like adequate and inadequate in here, and I'm just thinking enforcement point of view, where how are we going to come up with a number for adequate staffing? Meaning, let's say I run a compounding pharmacy. What is adequate for that? And it goes back to the comments I made during our QA forum. There are so many varying factor, and the whole industrial engineering that plays a role, right? It is how many steps does a pharmacist take to go consult, and it would vary from A pharmacy to B to C, and the type of setting, um, from that to a community setting, does immunizations and other things compared to a closer facility that might not be doing so. How is the board going to determine that number? What I'm saying, it's like how many scripts can a person fill, let's say, in a day or per hour. So SB 1442 was passed, and it whenever a pharmacist is working alone and they get busy, they should be provided with help, and all of those regulations are already there. So I don't know. My mind is just thinking out loud that it where do we draw the line with being adequate and not adequate? And then there are other things which are covered by robust labor laws we have in the state. For the rights of anybody working are pretty well covered, including some of the things OSHA covers. So those are my thoughts, and I'll let other board members comment.
Thank you, Jig. I no means an expert in this, but I want to say there are some of our state labor laws that do already have certain rules that apply to pharmacists about time between shifts and things like that, but I could be wrong. So that might be a good question to look into for Anne and the team to report back, like what are already in place outside of the Board of Pharmacy. Jesse, you brought up Oklahoma and the staffing form. That one really resonated with me, particularly that it was the responsibility of the pharmacy, the pharmacist, or the pharmacy manager, PIC, on everyone to do that form. So it didn't fall to one person. They were all considered, in my understanding of it, that they were responsible for that form, partake in that process. So I agree. I think there's like a mix of some of these different rules that we would take all together. To your point, Jig, I don't know that we have to come up with a number. I think that's part of the beauty of the language that a lot of other states use is, we give people the flexibility to understand what is adequate for their site, but then there also has to be a mechanism in place that protects employees from employers saying, oh, this is totally adequate when it in fact is not. So we do need some kind of an objective way, but it doesn't necessarily have to be a specific number, if that makes sense. So that was my thoughts. What else? Anything else?
Yeah, this is Jessie. I'll just jump in a little bit, kind of going off of what you're saying. I know what Jig is saying is true in that, we're kind of getting into an area, and even just skimming through the law in Oklahoma, it is pretty vague in terms of what adequate and inadequate means. And this kind of goes back to something we've touched upon before, which is kind of establishing a staffing floor or a minimum, which may not necessarily have to correlate to a specific prescription number or volume, but it could even just be, one pharmacist has to work with one technician. Or, for example, if you're providing clinical services in an outpatient setting, you have to have at least one technician there. That way the pharmacist isn't going back and forth. Otherwise, you can't perform clinical services. So some kind of getting into the realm of not establishing numbers per se, but really making sure that there's sufficient staffing to allow pharmacists to perform clinical services without being interrupted.
Just have a couple of thoughts. Like just one, I think we started to talk about it, but what is current law in terms of like workforce, workload, hours, and is it just not getting enforced? And then also, I remember when we would have the pizza people call, and some of them talked about the store manager versus the pharmacist in charge, and for those like chain pharmacies having kind of conflicting, I guess, supervisors or roles, and I think that that's something that we should think about. Um, Especially if the store manager is wanting something else, but then the PIC is like, well, I need to do this, and then kind of who you know, who's in charge, right? And then I do think this idea of a staffing floor is a good one because at least it sets like a baseline. And I also want to like quotas. I reading some of the legislation they talk about, not having quotas, and I think that that's something that to talk to as well because that puts additional pressure into workforce, the error and the fatigue and the bad environment and the bad work environment. So just some thoughts.
Thank you, Kula. And I love that you brought up that issue around, the PIC or the pharmacist, and then having these other non-pharmacist people that you report to. I don't know that I specifically saw that in these laws, and I don't know that we can, but perhaps that's something that we want to think about as we're looking at this, making very distinctions about who can make these choices of adequate staffing and what needs to be done versus who cannot make those choices.
Yeah, I didn't see it in these laws, but I just remember when we had public comment, a few public commenters, kind of brought that issue up.
Yeah, no, you're spot on. I really appreciate that. Jessie?
Yeah, I just wanted to say that's a really good point, Kula. And maybe since, we're talking about numbering being such a difficult thing to put into place, maybe having some language that says sufficient staffing can be determined by the PIC so that the PIC actually does have the autonomy to determine what is actually sufficient staffing for the services they're providing at that pharmacy. I think that could be something we could potentially look into.
Yeah. I do like that, Jessie. I think there needs to be a little bit more than that because you will have situations where the PIC might be an owner and doesn't want to pay more staff or something like that. So I think we do need a mechanism for that as well for a pharmacist to have a role. That's why I liked the Oklahoma piece that it gave the staffing to all three as opposed to just one. But again, I don't know exactly how it'll work, but I think there's multiple pieces here. Anything else? Okay, this is great. This is such a good discussion. I love this. So thank you, members and moderator. I think we can go to open the lines for a public comment, please.
This is the moderator, and at the direction of the chair, I've opened up the Q&A feature for public comment. Members of the public, if you would like to make a comment on this item, please click the Q&A icon located at the bottom right-hand corner of your WebEx screen or use the raise hand function. Audio-only participants can use the raise hand by pressing *3 on their device. It looks like we have a couple requests, so I'm going to go with our raised hand first. Lanny Duong, and Lanny, you'll be given 3 minutes to speak and a 10-second warning. Oh, there you are. Please click the unmute me button when the prompt appears on your device.
I wanted to specifically thank Board Member Koenig for bringing up Pizza's Not Working. I'm involved with that grassroots movement, and I'm glad that she raised that point for us, that it is important to have language, and also in supporting Board Member Crowley's comments about having language and not necessarily a number that's not going to be a one size fits all type of situation. We know, even now that the PICS hands are often tied in these chain pharmacies by the district manager, and they have been rallying for their teams and requesting more staffing when it is needed, when they're short staffed. But those requests are being denied. And so I think if there's specific language, then that would be easier from an enforcement standpoint, versus trying to, pin down a specific number. Another suggestion, I don't know if this has been discussed, but some of the chain pharmacies, I think most of them only look at the number of prescriptions filled when they are, in their staffing model. And if there's any sort of language maybe requiring, sort of putting the onus on the chain pharmacies to come up, to make sure that when they are looking at how much staffing they need, that they're including all of the duties that the pharmacists are in charge of, including immunizations, and so forth. So thank you for your time, and I appreciate the discussion from the board.
All right, this is the moderator. Our next individual is Jazzy Gruwal. And Jazzy, you'll be given 3 minutes to speak in a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hello, Chair and board members. Again, Jazzy Gruwal with UFCW Western States Council. I have 3 quick comments to make. One is I'm uncertain if this board already has the authority, but it would be good to give the board the authority to look at staffing across all workplaces in the healthcare capacity when it comes to prescriptions filled and services pharmacists provide. So I think that's just a good thing to have, is to give the board that authority. The second thing is I would urge this board to include in the enforcement manual staffing as a mitigating factor when we're looking at disciplinary cases, and making sure that that is something that is considered if the pharmacist was adequately staffed or not adequately staffed, and the workload that they had. So something that can be added to that enforcement manual. And then lastly, appreciate the discussion around a staffing floor, which I think is just so urgently needed. I know SB 1442 is current law. That is something UFCW worked on and sponsored, but it is not being implemented the way that it was intended. And so pharmacists are waiting a long time, or having to repeatedly call their clerks to come and help them. And not all the clerks are as appropriately trained. And so pharmacists are having to train as they go, as they're overwhelmed and have a full workload. So having an enforceable staffing floor where there is someone there to assist the pharmacist at all times, that they're not having to ask for, that is fully trained on all their duties, would be a significant help to pharmacists. So thank you again.
All right, this is the moderator. Our next individual who has requested public comment is Mark Johnston. And Mark, you'll be given 3 minutes to speak in a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Board, this is Mark Johnston with CVS Health, licensed pharmacist in California for 32 years. I want to thank the board for the conversation today. It's been really enlightening. The focus on trying to increase public safety and not to enter into a kind of a I got you scenario has been really refreshing. I wanted to comment on some of the board materials. What's presented from Illinois is great, but it's only a portion of what was decided by that committee. These statutes were run not by the Board of Pharmacy, but by a separate panel that the governor put together at the request of the public. It was chaired by a former board member, Phil Burgess, and there were members from all sectors on that panel including unions. They did meet monthly for literally years to come up with these outcomes. And the outcomes are really supported by all, but what you have in your packet is just a portion of the outcomes. As an example, one of the outcomes were expanded technician practice. The committee clearly thought that a solution to pharmacist working conditions was to expand pharmacy technician practice. For example, they passed the statute before the pandemic and before the PrEP Act that technicians should be able to immunize in Illinois. So I would encourage you to look at the entire Illinois outcomes and not just a portion of it. As I look at Oklahoma, I think it's important for the board to consider what an error is. I mean, the great discussion today is an error leads to a potential patient outcome. I haven't heard the board say that an error is the patient's address lacking on a prescription, the provider's address lacking on a prescription, or any technical details that would lead to an error such as Oklahoma considers it. So again, I enjoy the focus on patient safety that you've had today. Lastly, I have to mention that the information that's in the article in Virginia, considering CVS's fine is incorrect. That looks like it was from some newspaper article, some newspaper I'm not familiar with. It is not fact. That is not what the board actually determined. And so I would encourage the board to go back and publish actual outcomes instead of just what some newspaper erroneously reported here. And that's all I have for now. Thank you very much. I enjoyed the 3 minutes instead of 2 minutes. Thank you so much.
All right, this is the moderator. Appears that was our last request for public comment. Would you like me to close that Q&A panel?
Yes, please. Great. Members, there appears to be a general consensus that as a committee, we believe additional authority is appropriate. Given that, if the committee is agreeable, I will work with staff to develop a possible proposal that could serve as a framework for our future consideration. I see nodding. Okay. Let's move on to agenda item 7. Discussion and consideration of just culture approach to managing patient medication errors and patient safety. Members, we occasionally hear reference to just culture as a means of managing patient medication errors and patient safety. The Institute for Safe Medication Practices has some good information on just culture, including how a pharmacy organization can adopt such an approach. You will note from the meeting materials, a just culture is not a non-punitive or a blame-free culture. Rather, it is one that focuses on the entire system to evaluate what occurred in an error and what future action can be taken to prevent such errors. The meeting materials include some of the basic tenets. I have had the opportunity through my current employer to both participate in and observe the direct impact of a pharmacy implementing such an approach. So my organization has been working on just culture for a number of years. We started working on it prior to the pandemic, so obviously COVID made some of our actions take a little bit longer, kind of took precedent. But I can say in my experience, a lot of the things that we are talking about today, including requirements for what we would want included in the quality assurance and the medication error reports, we already do. We include who was part of an error. And again, not because we're putting the blame on that person, but because we want to interview that person and we want to talk with that person and find out from them what contributed to that error. We don't assume it's just that they did something wrong. And in using this approach, we use either a fishbone diagram or a technique called the 5 whys, which means that when you find that error, you have to go back at least 5 steps and asking, why did that happen? Why did that happen? Why did that happen? And in taking those extra steps, what would have originally seemed like a personal error, like this one person made this mistake, we've gone backwards and found system errors that contributed. For example, in one occasion, we found that something in our software had changed in an update and we weren't aware, and it contributed to an error. But had we stopped at just that basic looking at it, not interviewed the technician and followed through, we would have just blamed that tech, and that error could have continued happening because of that software issue. We were able to get it resolved, and we have not seen that error occur since. My employer also, we're the pharmacy, but we work with the clinic, and every department has our own QA program, and we go together and report out quarterly on all of our QA work, what we're doing, what errors we're seeing. Again, in this case, we're not going to talk about individual employees, but the systemic problems they're seeing, and then we can match problems across departments. Is there something about our software that's not interacting correctly? Is there an issue with our phone system? So we can look for more things. So this has been a long-term ongoing process. You do not get to just culture overnight. As the word culture implies, it takes a lot of time to get everybody on board and used to the new system. But overall, we're seeing an improvement in outcomes. We're seeing a decrease in errors. And we're seeing more collaboration between departments in using this system. So that's been my experience. Members, do any of you have experience with Just Culture or comments on Just Culture and the use in pharmacy?
Hi, Nicole. Thanks for sharing your story. Absolutely, same with my organization, but I, in general, just speaking in support of Just Culture, we should try to be mindful. To err is human. Is that the right? I don't know, but you know, we are all aware. I think this board takes seriously the approach that's needed to make sure we respect Just Culture, and that's all I have to say.
Thank you. Anyone else? Jesse?
Hi, Nicole. My organization doesn't necessarily use a Just Culture approach, but I definitely support looking at that systematic kind of viewpoint of errors. I like that your organization goes back five places before the error, and it just reminds me that there are software issues that contribute to errors. I've caught some myself, and a lot of the times when a pharmacist is working and maybe they see something that doesn't look right, but they assume that the software is right and they start to second guess what they know. So I think that's an important factor when we're kind of evaluating medication errors, and this sort of approach allows us to assess that.
Yeah, very true. Yeah, I think it's also important to note that in our Just Culture work, at least in the pharmacy department, we have never found someone like being egregiously negligent or anything like that. At worst, people were distracted. And we could almost always find, with the exception of an error that occurred at a time period before where they couldn't remember, but we've, besides that, always been able to find systemic issues that contributed. Doesn't always mean we can solve them quickly like that, but it at least shows us what things contributing. And when we had higher workloads or longer lines, those are definitely contributing factors in what we found. And it's a very, very clear pattern for us. So I think that's why this is really important to what we're doing. So are there any other member comments? Jig, I see you come off mute.
Absolutely. Yes. You know, Just Culture is very important. The places I'm involved with, I see that inclusion and, you know, taking perspective from different employees, groups, it's so important. And just that bringing that courtesy, dignity, and respect regardless of the hierarchy of management, to where that employee belongs, that only benefits the entire institution to do the work right. I mean, who wants to make an error? Let it be a company, hospital, any institution that's in there. Nobody wants to do that. And I feel that when everybody is included, there is the courtesy, dignity, and respect is the prime focus, and a solid feedback system where everybody involved gets to voice their opinion in practically whatever could be implemented to make a difference and to make everybody's life better. So everybody feels like waking up in the morning, going to work, and every patient that the community is serving, our employees are serving, um, feels that from that professional. So, I definitely believe that, just culture and the importance of it in success for all plays a very crucial role. Thank you.
Thank you, Tig. Kula?
Yeah, I just have I guess my question or my thought is like, to what extent does this approach with just culture appear in our enforcement disciplinary mechanisms, right? So, or maybe does it, maybe it doesn't know. I'm just, yeah, like when, someone's on probation or their license is, revoked, like to what extent, or can it or should it, play a role in that?
Yeah, I could jump in if that would be helpful.
Yeah, thank you, Ann.
This is Ann. Yeah, so cool. I think probably the most prominent place where you're going to see this in a disciplinary matter is where the respondent is providing mitigation, where they're talking about maybe, system changes that they've made or additional training that they have secured at the individual level. I would say that in general, we sometimes see that from a pharmacy as well. Maybe they've hired a consultant and they've implemented X, Y, and Z. So typically that is reflected both in the board's disciplinary guidelines, where you all talk about the fact that you want to, consider all of that mitigation. And so you've detailed some of that out in the disciplinary guidelines. With respect to maybe like some investigations that maybe don't result in discipline, again, through the investigation process, investigators are typically asking, trying to ascertain what happened, that QA report, if it's available, may provide some information as well, but you're interviewing the individuals involved and those kinds of things. I think where they're, no, I better not say that. Sometimes it feels like there's a little bit of a disconnect is what I will say in terms of what information we can solicit maybe from that pharmacy in terms of what's been done versus what we can get from the individual themselves.
Thanks, Ann.
Thank you, Ann. That was helpful. If there are any other member comments? No? Okay, then I'm going to go ahead and ask the moderator, can you please open the line for public comment?
This is the moderator, and at the direction of the chair, I have opened up the Q&A feature for public comment. Members of the public, if you would like to make a comment on this item, please click the Q&A icon located at the bottom right-hand corner of your WebEx screen, or use the raise hand function. And audio-only participants can raise their hand by pressing *3 on their device. All right, and it looks like we do have a request for comment from John Gray. John, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, good afternoon. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. Thank you very much for including this very important discussion on the committee's agenda. At the July 2022 full board meeting, I expressed our concern about the frequency with which pharmacies and pharmacists are issued citations and fines related to medication errors. While we recognize that definitionally citations and fines are not disciplinary action, perception is reality, and I have observed that pharmacists who receive a citation and fine from the board certainly do perceive it as discipline. I really appreciate Chairperson Thibault's perspective on working within an organization that uses a just culture approach. We recognize that the board is a regulator and is charged with protecting California consumers and probably cannot implement a just culture approach that is identical to individual organizations. I also really appreciate Board Member Koenig asking the question about how the just culture approach is considered in the board's disciplinary role. However, I do want to reiterate our comments from the July 2022 full board meeting. Our concern about the board's current citation and fine approach to medication errors is likely causing a chilling effect on medication error reporting and medication and safety improvement efforts. The bottom line is that self-reporting of errors is stifled by fear of disciplinary action. When clinicians fear punishment, they tend not to report all errors. As you know, when errors go unreported, the opportunity to learn from the error and improve the organization's safety systems is lost. During today's meeting, the committee discussed a number of possible changes to the board's requirements for pharmacies to review and document the circumstances of medication errors and perhaps even report medication errors to the board. I'm highly skeptical that the board will be successful in enhancing the quality assurance program and visibility to medication errors in the ways that are being proposed while still frequently citing and fining pharmacists involved in medication errors and the pharmacies in which the medication errors occurred. Therefore, we recommend either reevaluating the board's current approach around issuing citations and fines for medication errors or reevaluating the feasibility of the changes being discussed today, because to attempt to have both feels like an attempt to have your cake and eat it too. So with that, again, I really want to thank you all for including this as a agenda item and also for just all of the discussion today. Again, really appreciate it. Thank you.
All right, this is the moderator. Looks like that was our last request for public comment. Would you like me to close that Q&A panel?
Yes, please. Great, thank you. And thanks to all the commenters today. I appreciate such a good discussion that we're having. So thank you, everyone. As there appears to be an interest in learning more about just culture, I will ask staff to arrange for our presentation at a future meeting. Members, we have one more major topic. Are we good to keep going? Does anyone need a break? How are you all doing?
I'm good to go. Keep going if everyone's okay.
All right. Hearing no requests for a break, I'll keep going. So we can move on to agenda item 8. This is the discussion and consideration of the Pharmacist Wellbeing Index State Report. Members, including in our past meeting, has been information on the Pharmacist Wellbeing Index. As you may recall, we received a presentation on the index as part of our last meeting. Included in attachment 2 is a copy of the most recent state report. There has been an increase in the number of California pharmacists using the index, as well as a slight increase in the distress percentage for pharmacists licensed in California. The updated pharmacy workplace and well-being reporting, which includes data from January 10th, 2022 to August 11th, 2022, includes 14 positive experiences and 159 negative experiences. The negative submissions included categories focused on staffing and scheduling, workload and workload expectations, working conditions, pharmacy metrics. Regrettably, as I reviewed the information, numerous pharmacists reported verbal or emotional harassment, physical harm, including by patients, and discrimination. Relating this information to the specific well-being index, individuals reported that the factors increased stress, increased burnout, weakened family and personal relationships, and lessened happiness. Members, what are your questions or comments on the well-being index?
This is Jessie. I would be curious if we could keep an eye on it over the next few months as, you know, the newest booster just rolled out, and with flu season, I think kind of tracking those changes and seeing how well-being changes throughout the year would be really useful for us to see as a committee. So if there's any way for us to get that information for future meeting dates, I think that would be very useful.
Anyone else? Other comments?
Hi, this is Jig. Definitely, the pandemic took a toll on everybody. I do see some emotions in there. But like Jesse said, let the time go as hiring becomes a little bit easier for some of the setups. I think everybody is still struggling to hire, and we are still in the middle of COVID vaccinations, and which has been on top of everything else that we did, right? That was additional. So it'll be interesting how things pan out over a period of time.
Great, thank you. Anyone else? Yeah, I completely agree with you, Jesse. I would love to see this over time. I was really pleased to see that a number of pharmacists went ahead and participated after we had discussed it. It might be interesting or helpful for the board to send out an ask or a reminder about the index, maybe a couple of times a year, something like that, because I think following this will be a good way to help measure some of our interventions as well, and kind of relate to what we're doing. So I'd love to see that. If no other members have comments, moderator, can we go ahead and open the line for public comments?
This is the moderator, and at the direction of the chair, I've opened up the Q&A feature for public comment. Members of the public, if you would like to make a comment on this item, please click the Q&A icon located at the bottom right-hand corner of your WebEx screen, or use the raise hand function. Audio-only participants can use the raise hand by pressing *3 on their device. And I'll pause a moment to allow the public time to access that Q&A panel and submit their requests. All right, and it looks like we do have a request for comment from Lanny Duong. And Lanny, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, this is Lonnie Duong, licensed pharmacist in California. And I just wanted to thank the board for having this on the agenda as well. I think it's really important just personally. And my question is what the board sort of has in mind in terms of a plan of what to do based on the data that's coming from this survey. I think it's, clear and sort of like beating a dead horse that, the pharmacy world, the retail pharmacy world is in dire straits. And I don't see the staffing issues being resolved anytime soon. The new COVID booster is coming out. We're upon flu season, and pharmacists are still leaving chains like en masse. And so if there is any actions or support that we're sort of in the pipeline down the line based on the data coming from this survey, I would ask that be considered, to be moved up and not wait for additional data to support what we already know is happening now and not slowing down anytime soon. If anything, it would, the pharmacists are going to be more inundated because COVID's not going away. Thank you so much for your time. I really appreciate all the discussion today. And thank you.
This is the moderator. It appears that was our only request for public comment. Would you like me to close that Q&A panel?
Yes, please. Thank you. And thank you for your comment. We'll definitely keep that in mind. So we will continue to monitor these well-being index reports. And I believe that the Communication and Public Education Committee is developing a campaign to educate the public about pharmacists and the important role that they play in patient health. And that was on the recommendation of KULA. So thank you for that. So more to come in that realm. And I think now we can move on to our last agenda item, which is agenda item 9. And this is our future committee meeting dates. So our next meeting is scheduled for November 16th, 2022. And that is it for today. So thanks everyone for your time and attention, and meeting is adjourned.
Thanks everyone. See you in
Chair Tebow. Bye everyone.
Bye.
Thank you.
Thank you. Bye.